Giant cell arteritis and polymyalgia rheumatica. Giant cell arteritis is a granulomatous arteritis that affects any large, including aorta and medium-sized arteries. It is commonly associated with polymyalgia rheumatica, which presents with symmetric immobility associated neck and shoulder girdle pain and stiffness. Since many patients with giant cell arteritis have symptoms of polymyalgia rheumatica, and many patients with polymyalgia rheumatica go on to develop giant cell arteritis if untreated. Many rheumatologists consider them to be different manifestations of the same underlying disorder. Both diseases are rare under the age of 60 years. The average age at onset is 70, with a female to male ratio of about 3:1. The overall prevalence is about 20 per 1 lakh in those over the age of 50 years. Conditions that can mimic polymyalgia rheumatica, that is calcium pyrophosphate disease, spondyloarthritis, hyper or hypothyroidism, psoriatic arthritis, enthesopathy, systemic vasculitis, myeloma, inflammatory myopathy, particularly inclusion body myositis, Lambert-Eaton syndrome, multiple separate lesions, cervical spondylosis, cervical radiculopathy, bilateral subacromial impingement, facet joint arthritis, osteoarthritis of the acromioclavicular joint. Now the clinical features. The cardinal symptom of giant cell arteritis is headache, which is often localized to the temporal or occipital region and may be accompanied by scalp tenderness. Jaw pain develops in some patients brought on by chewing or talking. Visual disturbance can occur, most specifically amaurosis, and a catastrophic presentation is with blindness in one eye due to occlusion of the posterior ciliary artery. On fundoscopy, the optic disc may appear pale and swollen with hemorrhages, but these changes may take 24 to 36 hours to develop and the fundi may initially appear normal. Rarely, neurological involvement may occur with transient ischemic attacks, brainstem infarcts, and hemiparesis. In giant cell arteritis, constitutional symptoms such as weight loss, fatigue, malaise, and night sweats are common. With polymyalgia rheumatica, there may be stiffness and painful restriction of active shoulder movements on waking. Muscles are not otherwise tender, and weakness and muscle wasting are absent. Other conditions that cause PMR-like symptoms are shown in box 2466. Now, investigations. The typical laboratory abnormality is an elevated ESR, often with a normochromic normocytic anemia. CRP may also be elevated and abnormal liver function can occur. Rarely, PMR and GCA can present with a normal ESR. More objective evidence of giant cell arteritis should be obtained whenever possible. There are 3 investigations to consider: temporal artery biopsy, ultrasound of the temporal arteries, and 19-fluorodeoxyglucose positron emission tomography, that is 19-FDG PET scan. Characteristic biopsy findings are fragmentation of the internal elastic lamina with necrosis of the media in combination with a mixed inflammatory cell infiltrate. Diagnostic yield is highest with multiple biopsies and multiple section analysis to detect escape lesions. A negative biopsy does not exclude the diagnosis. On ultrasound examination, affected temporal arteries show a halo sign. A strongly positive 19-FDG PET scan is highly specific, but sensitivity is low. Caution is needed in interpreting weakly positive images. Low-grade vascular uptake may occur in atheromatous arterial disease. Now, management. Prednisolone should be commenced urgently in suspected giant cell arteritis because of the risk of visual loss. Response is dramatic, such that symptoms will completely resolve within 48 to 72 hours of starting therapy in virtually all patients. It is customary to use higher doses in giant cell arteritis, that is 60 to 80 mg prednisolone, than in polymyalgia rheumatica, that is 15 to 20 mg. Although the evidence base for this is weak, in both conditions, glucocorticoid dose should be progressively reduced, guided by symptoms and ESR, with the aim of reaching a dose of 10 to 15 mg by about 8 weeks. The rate of reduction should then be slowed by 1 mg per month. If symptoms recur, the dose should be increased to that which previously controlled the symptoms, and reduction attempted again in another few weeks. Most patients need glucocorticoids for an average of 12 to 24 months. For advice on prophylaxis against giant cell induced osteoporosis, see page 1047. Here the box showing emergency management of giant cell arteritis. Take blood for CRP, ESR, full blood count, bone, liver, renal function, serum protein electrophoresis, CPK, rheumatoid factor, ACPA, ANA, ANCA, complement C3 and C4, immunoglobulins, parathyroid hormone, TSH, vitamin D, and urine electrophoresis. Commence prednisolone 40 to 60 mg daily and simultaneously weekly oral bisphosphonate and calcium with vitamin D supplements. Consider urgent ophthalmology examination and temporal artery biopsy in patients with visual symptoms. Consider obtaining temporal artery ultrasound or 19 FDG PET scan. Review within 1 week and adjust glucocorticoid doses according to clinical response and results of investigations.